Okay, so we're on to the second session today, and just before we start, can I ask that if anybody who hasn't signed the attendance sheet, if you could sign it at lunchtime, that'd be great. We're just obviously keen to get our numbers correct. Also, we found a mobile phone, so if anybody's missing a mobile phone, there's one here today. We've had a few calls to Australia, but other than that... and speaking of Australia, our next speaker, our keynote speaker, is Miss Joanne Fitzgerald, who, as I said, has been promoted since we've produced this timetable. So she's now interim CEO of the Independent Hospital Pricing Authority in Australia. And I'd like to thank Joanne for coming over, making the long journey to be our keynote speaker here today. I think as was noted in the ED selection process, one of the reasons for choosing the Australian system is the level of support that we get from Australia. And, it's a great sounding board for anything we do is what's happening in Australia. So on that note, Joanne is going to give us an update in relation to things that have happened in Australia in the last 2 years, including the COVID situation. So, thanks, Joanne.
Thank you very much indeed. Very pleased to be here. Let me just get my slides moving. What am I doing wrong here? So I wanted to start with a bit of a discussion about what brings us together, Australia and Ireland. And obviously, our healthcare classifications, the ARDRG system, activity-based funding. From my perspective, the greatest benefit of this for me is that I get to come to Ireland every now and then and present at events like this. That invitation is reciprocal. Anyone who wants to visit Australia, we will host you, we will tell you what we're doing, and we will make it look like a work trip for your bosses here. So I promise you that. But the similarities don't end there. We are blessed to both have national football codes that are so popular they're not played in any other countries other than our own. And the third thing we have in common, at least in summer this year in Australia, was rain. A lot of rain. So our 21-22 summer in Sydney, we had over 655 millimetres, which is not that different to, I believe, Dublin's annual rainfall of about 755 millimetres. So we may yet give you a run for your money with wet weather this year. I am happy to hand that mantle back to Ireland at any time. So I'm just going to quickly recap a bit about the Australian health system, just to sort of draw some similarities and comparisons to some of the information you've had today. We obviously have a universal health insurance scheme, so that's Medicare, so we have a public system. Healthcare is provided free for those who need it. A lot of people do elect to have private health insurance though, and there is a significant proportion of private health activity in our country. We have approximately 700 public hospitals and 600 private hospitals. We have about 11 million separations a year, and about 60% of those are in public hospitals. So to compare some of the activity stats to some of the numbers that have been talked about this morning, we have about 6 million admitted acute separations in public hospitals each year. We have about 8 million ED presentations and about 38 million outpatient service events each year. Our health system is funded by different levels of government depending on the level of the health system. So for our public hospitals, that's a combination of funding from both the Commonwealth and from the states and territories. So perhaps I should say when I talk about Australia being a federation, and so when I talk about the Commonwealth, I mean the federal government, and then when I talk about states and territories, that's obviously pretty self-explanatory. But so our public hospitals are jointly funded, with the Commonwealth contributing about 45% and states and territories 55% of public hospital funding. The Commonwealth is predominantly responsible for funding primary care and for funding aged care, but community care and public health is predominantly the states and territories. So there is a lot of complexity in the system, and there is a lot of debate and discussion around who's responsible for what. Issues in the public hospital system, are they the responsibility of the states and territories? It does create some challenges when you're in a federation. Just some stats. This is a bit out of date now, 17-18, but it was the most recent I could find in preparing this presentation. But on an annual basis, in Australia, we'd spend about $185 billion on healthcare, and about 127 of that will come from governments, and obviously the remainder from other sources. For hospitals, we're looking at about 57 billion, and a GDP is about 10%. Health's share of GDP is about 10%. And just to compare that to Ireland, where Australia's red and Ireland's blue there, so you can do a bit of a GDP comparison about where we are on health spending. Okay, so a bit about the agency that I work for. So we've been around since 2011, and we were formed and established as part of what's called a National Health Reform Agreement, where the Commonwealth and States and Territories negotiated a new health reform agreement and implemented a new method of funding public hospital services. And so that led to the establishment of activity-based funding as the primary mechanism for Commonwealth funding to states and territories for public hospitals. So a number of states and territories had activity-based funding for years before that. That's how they distributed their budgets within their state. But at the Commonwealth level, the previous arrangements were essentially 5-year negotiated healthcare agreements with block funding negotiated between the Commonwealth and states and territories, and it was very difficult, very unpopular. Commonwealth thought states and territories were just continually asking for more and no guarantees that was even being spending on health, maybe spent on useless things like education and roads and other infrastructure. And states and territories didn't feel that the Commonwealth was keeping up with the growth in hospital services. So activity-based funding was established, and part of that establishment needed an agency to set the price. The states and territories would not agree to an agreement which was resulting in the Commonwealth setting the price. They didn't think that was fair. So they set up an independent agency, which is the Independent Hospital Pricing Authority. And we are governed by a board. The board is independent, made up of 9 members. The CEO is appointed by the board. And the board cannot be directed by governments on price. So there's legislation which says the board has determinative functions, and so the price we set is what the Commonwealth has to pay for public hospital funding. So we're independent of all governments, but we obviously work very closely with all governments. Our major stakeholders are the Commonwealth and the states and territories. We work very, very closely with them. We have regular meetings with them, and we have a strong consultation and transparency agenda, not just with all of the jurisdictions, but also with the health sector more broadly. So we consult on a public consultation basis, on an annual basis, on our annual pricing policy. And so it's not just states and territories in the Commonwealth who make submissions. Hospitals can do that, peak bodies, professional organisations. Any classification development we do, we also publicly consult on that as well. The public can make submissions for improvements in classifications and for changes to the pricing model. So we're very much about consultation. Transparency, many of you will have probably seen documents on our website. Everything we do is published, everything is available. We make all of our data sets, our pricing models available to all of the jurisdictions. We want them to replicate the models. We want them to find issues with them if there are there, and we want them to suggest alternative methodology. Like we do really come up with our best products when they are thoroughly scrutinised and critiqued, and we are open to submissions and ideas on how they can be improved. And our board very much takes the view that determination should be evidence-based. So there's a lot of, often there's a lot of commentary, there's often a lot of media, a lot of political opinion, but the board makes pricing determinations based on evidence and based on cost data. So our main function is on an annual basis determining the national efficient price. So that will determine the Commonwealth proportion of funding that goes to public hospitals. We also have this thing called the national efficient cost, which we also determine on an annual basis, and that's for hospitals that are not suitable for activity-based funding. So they're generally small, rural, regional hospitals that the economies of scale are not there. So we do calculate the national efficient cost for those services. So there are about 400 hospitals at the moment that are block funded, which out of 700, I know seems like a lot, but they represent only about 5% of total hospital activity. So the vast proportion of public hospital activity is subject to activity-based funding. So these fundamentals of ABF are probably not new to you, as also experts in ABF, but they also nicely illustrate, I guess, the four functions of what we do as an agency. I've talked about the headline figure of the national efficient price, but that is not the only thing we do. There are other areas that we need to develop and set standards for in order to determine that price. So for any ABF system, including the one we have in Australia, we need 4 key elements. We need activity data, which we currently get from states and territories on a quarterly basis. So that's similar to your hype data, your activity, your separations, your clinical, your demographic, and your classification data. Then obviously you need a way of classifying and categorising that activity. So I've got another slide which will talk about the different classifications that we use. Then obviously we need cost data. So we receive cost data on an annual basis from states and territories through what we call the National Hospital Cost Data Collection. And we also do receive some cost data from the Commonwealth for schemes that are funded by the Commonwealth, such as pharmaceutical benefits or blood and blood products, so that we can, in developing the pricing model, ensure that any other Commonwealth contribution is removed in setting the price, so the Commonwealth isn't paying twice for things. And so that last element obviously is the pricing, and we produce that national efficient price determination, which includes a single national efficient price plus associated price weights and adjustments. So obviously ABF needs all of those 4 elements. Even if you don't use pricing and funding, those first 3 of data, classification and costing are essentials in running any sort of health system and essentials in running any sort of pricing or funding model, be that ABF or an alternative. So here's a rundown of the classifications, many of which you'll be familiar with because you are using currently or intending to use. Obviously ARDRGs is the one that everyone will know, and that's for admitted acute care. I don't believe this is one that you use for subacute care. So we have admitted subacute care, which is predominantly rehabilitation and palliative care. And so we have a specific classification in Australia for that called the Australian National Subacute and Non-Acute Patient Classification. And so it's a classification that's largely based on patient functioning rather than diagnosis-related groups. We have, for emergency care, we formerly used the urgency-related groups classification, and we have recently developed a new classification to make improvements called the Australian Emergency Care Classification, which I will go into later on in my presentation. We use Tier 2 non-admitted services, which Lorna covered in her presentation, and I'm not going to cover any more today. And for mental health care, we also have a reasonably new Australian-developed mental health care classification, which covers both admitted and community mental health care, and I'm going to cover that a bit later on in this presentation. So looking at those fundamentals of ABF, we've talked about the data and the classifications and the costing and the pricing. How that actually translates to hospital funding is IPA determines the price, and the states and territories determine the volume of services. So each year, states and territories provide their estimates of what activity they're going to deliver, where those services get delivered, how much of them, who delivers them. That's entirely the responsibility of the states and territories. IPA or the Commonwealth does not get involved in that. So where and when is completely up to the states and territories. But so those activity targets are provided by states and territories. That goes to another national agency called the National Health Funding Body, who handle the cash. And so the National Health Funding Body uses those activity estimates, applies our pricing model, and that determines the funding that gets distributed on a regular basis to the local hospital network level and from there to individual hospitals. So just a couple of key terms that I will probably slip into in this presentation at various times, but they are 2 key elements of our pricing models. The first is the NEP, that's our national efficient price, and it is essentially based on the average cost of an admitted acute episode of care. So that NEP is a single figure that we use and then we index forward for the purposes of pricing. And the National Weighted Activity Unit, which we call the NWAU, that is essentially a common unit of activity which is weighted for complexity and length of stay. And it's a common unit of measurement for all hospital services. So when we talk about an NWAU, that NWAU can be looked at in comparison to different types of hospital services. And it is influenced by length of stay and cost. So to illustrate that a bit more, so we have the NEP, which I've just put our most recent NEP for 22, which covers the 22-23 financial year. So a single price, I did do a quick Google currency conversion for you, that 5,797 is approximately €3,818. And then if you look at the different types of hospital care, for example, we have an admitted acute episode or a subacute episode or a non-admitted event or an emergency department presentation, that NWOW shows the complexity of that event or that hospital activity in comparison to each other. So obviously price times NWOW gives you what the average price of that particular service is. So comparing a hip replacement to an episode of rehabilitation for spinal cord injury, compared to an emergency presentation for asthma, compared to attendance at a urology clinic. So that's all a common weighted activity unit, and that's in comparison to each other. How we develop our national pricing model, this diagram represents that. So we start with our activity and cost and classification data, and so we combine that into a single national data set, which has those 6 million admitted acute episodes of care, if we're looking at the acute cost model, along with the classification data and the cost of that particular episode of care. And that allows us to determine for each N-class, for each DRG, a cost profile. That cost profile is then turned into a price profile through the application of various adjustments, which I'll talk about. And that leads to ultimately the publication of our NEP, our single NEP, plus the associated price weights and the adjustments. We also have a process of consultation, as I said. That's a public consultation plus an in-depth consultation with all jurisdictions on the price determination before it's published. That goes to health ministers for review. As I said, we can't be directed, but we do provide it to them for review and provide an opportunity for them to submit comments. And we also do an independent QA because our pricing model is obviously quite complex, and we need to ensure that there's no error in the modelling that's unintentionally been introduced. So in terms of that cost profile, this sort of trend line might be familiar, the line trending upwards, which is the cost increases with length of stay. But this illustrates how we determine our cost profile. So for a particular N-class, so this is a DRG, we look at what the average cost is, and then we work out a lower bound and an upper bound. And that's generally, for most DRGs, that's the average divided by 3 for the lower bound and times by 3 for the upper bound. And that gives us an inlier range. And so our admitted acute model is based on an inlier-outlier model. So if you've got an episode of care that's an inlier, you'll get an inlier price weight for that episode, so a single price weight. If you're a short stay outlier, so you stay less than expected and less than the average, then you will get a short stay outlier per day payment. And if you're a long stay outlier, you get your inlier rate, and then for your days outside the upper bound, you'll get a long stay outlier per DM. So it's not purely an episode model, it is based on episode and length of stay. So that's what that cost profile looks like. So I mentioned the cost profile and turning that into a pricing profile. That involves applying a number of pricing adjustments. So we apply pricing adjustments if there are legitimate and unavoidable variations in cost that are not accounted for in the classification or that are not suitable to account for in the classification. So in Australia, we obviously have Indigenous First Nations people, and they generally are more costly to treat, regardless of where they are, what hospital they're in, what DRG they're in. And so we apply an adjustment for any Indigenous patient on top of the price that they would get for that DRG. We also have, this is not an exhaustive list, this is just examples, but we also have for patient remoteness, obviously Australia being a very big country, we have some people living in remote areas, and we have some hospitals in some very remote areas, and they are generally more costly. And we also have, when the classification doesn't go all the way to explaining complexity, we do consider adjustments for things like dialysis. So if you're a patient admitted to hospital for something else and you receive dialysis treatment, we have a dialysis adjustment. Same with radiotherapy. The most important thing about pricing adjustments is that they have to be identifiable in the national data collection. We do get a lot of submissions quite regularly for factors that stakeholders view are making patients and episodes of care more expensive. If there's data that we can do to test that, we do test that. Sometimes there is not data available, and so depending on what the situation is, we might look at potentially what sources of data could be used, or whether there's value in implementing changes in national data collections to get that collected. In other cases, we essentially just can't apply a pricing adjustment because we don't have any data on which to evidence that. Okay, so now I'm going to move to what's changed since the 2019 ABF conference in Ireland. Obviously, a lot has changed in the world, and a lot has changed in the ABF world and in Australia. And I would say the greatest challenge for IPA, and no doubt for your own healthcare pricing office, has been managing the COVID-19 funding arrangements, but also trying to maintain those ABF systems in a world where there has not been averages and certainty and consistency. So I'm going to talk a bit about the COVID-19 experience in Australia, about the sort of COVID arrangements that were implemented and agreed by all governments, and then about what we're doing for pricing sort of moving forward once those sort of short-term measures are no longer with us. So this is just a bit of a timeline of what things look like in Australia, probably very different to Ireland, or it probably started off quite similar and then it took a slightly different trajectory. So we had our first reported case in January 2020. I don't think any of us took it really seriously. I don't think we thought it was going to be what it was going to be. But obviously, along with the rest of the world, in around March 2020, we thought actually this is probably quite serious. And we went into national lockdown. Non-essential businesses were forced to close. Elective surgery was cancelled. And we all worked from home until about early May 2020. And then the numbers were significantly reduced. We had very strict international border closures, so we didn't have a lot of people coming in, and so we were able to essentially almost eradicate COVID in the community. So throughout the rest of 2020 and going into 2021, most of Australia had a pretty relatively COVID-free life, unless you were living in Victoria and in Melbourne in particular. In the second half of 2020, so starting in July, going to October, Melbourne was in lockdown and under very severe restrictions. That ended in end of 2020, and again we had probably a blissful 6 months where we were, thinking we were doing really, really great. And then in June, July 2021, we had another outbreak. This time it started in New South Wales. We went into lockdown, followed by Victoria, followed by Australian Capital Territory, and we were in lockdown until about October 2021. After that, vaccinations had happened, been rolled out. We had quite high vaccination rates. It was all really good. Restrictions loosened in early December. And then, of course, Omicron happened. And like the rest of the world, our Christmas 2021 was a bit different than we anticipated. But there's been no widespread lockdown since then. So October 2021 was essentially when the lockdown ceased. And we have been dealing with COVID as normal as we can. I guess the takeaway from that timeline is that the Australian states and territories had quite different experiences. There were some small, short-term localised lockdowns in some of the other states, like Queensland and WA, of like a week or 2 weeks, but not lengthy lockdowns. So the challenges for that for pricing has been that in essentially in the first 3 to 4 months of the 2020 COVID period, we had quite a similar national experience. After that, it was very, very different. Victoria had a very different experience to the rest of the states, and then in 2021, a very different experience again, which creates some significant challenges for us, obviously, in trying to unpick the different costs and the variations in the cost data that we're going to receive. Okay. I think that's right. That is right. Sorry about that. So just a few stats. We're probably cracked the 8 million mark now in terms of total cases, and probably getting close to 10,000 for the total deaths. We're still having probably about 50 deaths a day from COVID, and we're getting between 30 and 40,000 cases a day. But I think what you can see from that graph, I don't expect you to be able to see the numbers, but you will see that the vast proportion of our cases happened at the end of December 2021 and into 2022. We obviously did have cases in 2020 and 21, but they've been dwarfed by the cases that we have now. In terms of what happened to our hospital system, I imagine this is probably pretty similar to what you see in your own data when you look at it. We obviously saw a significant drop in hospital activity around March, April. It started to pick up again in May, June, as the lockdowns ended and elective surgery started to recommence. If we look at the 2-year period, you can see that the activity has picked up and that it got back to relatively normal levels, despite the lockdowns and despite that varying experience, although saying that I'm just looking at that now, that June 2021 was before the second set of lockdowns in New South Wales and the like. So we would expect to see a drop of activity during that time as well. So that's the activity. In terms of cost, again, this is probably not a surprise. The activity dropped, so that shows total cost and average cost, and this is not weighted for complexity in any way. This is just average cost, like total cost over number of separations. But you see, despite the fact that the activity dropped, the average cost continued to increase as additional costs to the system happened as they dealt with the COVID-19 pandemic. Okay, so that's what the activity and cost data looks like. These are the arrangements that the governments, so the Commonwealth Government and the states and territories entered into to provide additional financial assistance for hospitals and health services. So there were a number of payments. There was an upfront payment based on population of the state to essentially deal with sort of preparatory activities. Then there was hospital services payment where the Commonwealth would pay 50%. So I mentioned it's generally a 45-55 split. The Commonwealth agreed to pay 50% of all hospital-related costs for COVID or suspected COVID-19 patients. So that came through hospital services payment, like through the ABF process. Then there was a state public health payment for each state, and that's essentially a block grant for things such as additional PPE, contact tracing, increasing ventilator capacity, public education, enhanced cleaning, those sorts of things which are not necessarily suitable for an activity-based arrangement. And so those were paid on the basis of states and territories supplying evidence to the National Health Funding Body that was the amount paid for things like contact tracing and PPE. There was an update to the National Partnership Agreement to include a viability payment for private hospitals. So the Commonwealth Government was obviously very concerned that our private system, which largely relies on elective surgery, that they were maintained so that we could keep that capacity, but also so that those hospitals would remain financially viable. So the Commonwealth paid 100% of any costs that states and territories paid to ensure private hospitals remain viable. In addition to that, the Australian Government provided a funding guarantee to all states and territories that they'd be no worse off. That started out for 1920 and it got extended twice. Essentially what the Commonwealth said is that you supplied your activity targets based on what you would be what would you be providing in a normal year, and the federal government paid for that activity even though it wasn't delivered. So there was quite an additional amount of Commonwealth support. I think it was about $6 billion up to the end of 2020-21, and to put that into context, general ABF funding under the National Health Reform Agreement is about $21 billion. So it is a significant amount, but it's also probably pales in comparison to all of the other money that was spent on things like income support and other sorts of social and payment support. So I guess the message of that is the funding arrangements covered, it essentially meant ABF, we continued to determine our prices, we continued to publish our determinations, those were used to set activity targets, but at the end of the day, money was flowing through to states and territories, not just on the basis of our determinations. The federal government did agree to pay for essentially activity not delivered in order that states and territories could continue to manage their health systems. That concludes at the end of June 2022, which means we're back on activity-based funding, which means IPA has had one hell of a challenge trying to work out what the activity-based funding, what the price should be, what activity will look like in 22-23. So in developing NEP 22 and how do we account for the impact of COVID, well, a crystal ball was what we needed. If anyone knows what's going to happen in 22-23, what's going to happen to hospital activity and what it's going to cost, what costs are going to be enduring, I know it's our job to figure that out, but it's really, really difficult. None of us, I think, had any idea and know what's around the corner. So the approach that we took was essentially to clearly document the assumptions that we were making. Like, we knew we had to make assumptions on what 22-23 activity was going to look like. It's just there was no way around that. And our approach was, if we clearly documented those assumptions, then if what we assumed didn't actually happen and it didn't pan out and activity didn't return to normal, for example, then at least everyone would be very clear on what we've done and governments have a position to discuss, negotiate, come up with alternative arrangements if that's what they agree to do. Essentially, the Commonwealth and states and territories can agree to do whatever they want. And so that was sort of the approach that we took. So in developing NEP 22 and accounting for the impact of COVID, there's three elements that we had to look at. One of which is the price weight, so that's the difference in relative cost between the various DRGs or classification N classes. And the second component was the reference cost. So that's the average cost of an admitted acute episode of care. And so that reference cost is what's used when we index it to determine the final national efficient price. So that reference cost, we knew, had to be as accurate as possible to account for the increased costs as a result of COVID, but also to try and identify if those costs were enduring. Obviously, the Commonwealth is seriously concerned if we set a reference cost that includes costs which are not enduring and which were for initial management of the pandemic. States and territories obviously are greatly concerned if that reference cost is not high enough and doesn't adequately account for all of the costs that they think will be ongoing as a result of managing their services in this new COVID normal. And the third area we had to look at is the indexation rate. So the indexation rate is what we do to apply to the reference cost to project the fact that the cost data we use is 3 years old and it'll be used to set prices in a future financial year. So for the 22-23 prices, we used 2019-20 cost data, which had that last quarter impacted by COVID. And so what we do is we develop an indexation rate for each NEP and for each reference cost and apply that to reflect what the actual costs and price of those services will be for the 22-23 financial year. So what we, as I said, with the reference cost, we wanted a reference cost that accounted for the impacts of COVID and the increased costs, but didn't necessarily go overboard. And with the indexation rate, we wanted to ensure that we calculated an accurate indexation rate, which is generally based on an average of the previous 5 years NEP growth rate. We wanted to ensure that we didn't build in a step change into the indexation rate, that the step change will come into the reference cost, that those increased costs will be reflected in the reference cost, so they don't also need to be reflected in the indexation rate. So we started off with some hypotheses and basically used the data that we had, which was just 1 quarter of 1920 cost data, to test what those hypotheses were, and that helped us in determining that final NEP and on what our assumptions were. And our hypotheses were that the relative costs between the N classes will not be significantly impacted. So yes, the costs have increased, but if a particular DRG is 4 times more expensive than the average before COVID, that it's probably still 4 times more expensive than the average. And on the data that we saw, the data we looked at, that was actually pretty accurate, that the price weight relativities did not change significantly for particular DRGs and N classes. So that was good. That was an easy thing, an easy decision to make. The reference cost, our hypothesis that it would increase more than it would normally in a standard year, that there was that step change, that there were increased costs associated with COVID, and that it would be a sort of a higher growth rate for that reference cost than we would normally see in previous years. And our third hypothesis was that the index rate should remain comparable to previous years' indexation rates. As I said, that step change was meant to be covered in the reference cost, and the indexation should be reasonably comparable. And so most of our analysis did bear that out. With the indexation rate, we used the 1920 growth rate minus the COVID costs to ensure that we were calculating indexation on like-for-like from previous years. The reference cost was a very complicated piece of analysis, which I probably won't go into detail here, but it involved essentially taking the 2019-20 cost data. We had to put back activity that wasn't delivered in 1920 to obviously come up with an accurate reference cost. So that was a process that we called normalisation to essentially normalise the 2019-20 cost and activity data so that we could accurately calculate what the cost would have been. And then to separate what are those costs that we think are enduring related to COVID and which ones have been accounted for essentially under other government programs like that National Partnership Agreement. So we did get there. We obviously, you would have seen on the previous slide, we did get to an NEP. I think it's fair to say the Commonwealth probably thinks it's too high and states and territories thinks it's too low, and that's probably pretty situation normal. So I think we've done the best that we can do. These are not the full list of assumptions which are in our NEP determination, but these are the sort of, the high level ones. The assumptions that we've documented is that the activity, both volume and complexity through NWOW, will be in line with historical trends in volume. We have presumed that the price-weight relativities that we see in the 1920 data won't vary significantly in 22-23, and that the increased costs measured that we saw in a national hospital cost data collection will persist into 22-23. So as I said, if any of these don't eventuate, then states and territories and Commonwealth have an opportunity to negotiate. We have never reissued a determination, but there's, never say never. There is always agreements that the governments can reach, and they may ask us to do additional work. And obviously a big piece of work for us this year, not only in developing NEP 23, which we're in the process of doing at the moment, is actually monitoring these assumptions and providing advice to government about how accurate we were and are we seeing what we predicted pan out. Because obviously that will, we're doing that for the purpose of calculating the next NEP, but I'm sure governments will be very interested in what the outcomes are as well. So that's the COVID-19 impacts. But we didn't stop there with advances in ABF. So my next part of the presentation covers, I guess, some of the changes, some of the things which we've been continuing to progress alongside the COVID-19 work, and some areas that no doubt Ireland will consider at some stage. So first of all, thanks for Jerry's presentation on URGs. It was great. I know it was Emma's presentation originally, but means that I don't have to go into urgency-related groups quite a lot. But one of the advances I talked about is we have undergone a significant refinement of our emergency care classification. So this is not because of any issues with urgency-related groups. It's a great classification. We've used it for 10 years to price very effectively. But we always continue to look for ways to refine and improve our classifications. And, we've undergone a multi-year project to essentially come up with a significant revision and develop the Australian Emergency Care Classification. The great thing about it, well, for us, but also for you, is that it uses the same variables that are used in the URG classification, essentially. There's a couple of additional ones, but anything that we did for URGs, we were able to implement it quite quickly, because essentially it's the same data regrouped according to another classification. So whatever way you go with your emergency care classification, you will have the data that you need to choose whichever classification is most suitable for you. In Australia, for us, we have used it to replace the urgency-related group classification for pricing emergency department services from 21-22. So this is how it varies. So in Jerry's presentation, went through in quite detail sort of what the variables are for the URG, so I don't need to go through that. But to compare it, that first variable of type of visit in the new Australian Emergency Care Classification essentially just separates those emergency presentations from those did not waits, dead on arrivals, that sort of thing. And so episode end status is no longer the first splitting variable, whether the patient was admitted or not admitted. We actually group them into are the emergency department presentation, and if yes, then they're grouped into essentially diagnosis categories. So it's not that dissimilar to a diagnosis-related group, it's just one more suitable for emergency care. So type of visit, emergency department, the principal diagnosis, and then what we have is a complexity variable. So the third level of classification is essentially a complexity weighting. So you go into an A or a B or a C category, depending on a combination of variables. So one of those is the transport arrival mode, so whether they came in by police, ambulance, for example. Age is there, triage is still there. So obviously in the URG classification, triage is quite a significant variable. Triage is still in the emergency care classification, but it's now used in a combination with other variables to determine an overall complexity profile of a particular diagnosis group in emergency department. And same with episode end status, it's still there in the classification, we haven't removed it. We've just used it as one of the factors for considering complexity. And I guess the major advantage from our point of view of the AECC is about the potential in the future with that complexity variable for us to consider additional variables that maybe are not currently in the URG classification. So we don't have a lot of additional data for EDs at the moment. There's been a lot of talk about interventions and procedures and potentially other factors such as not so much additional diagnoses that you think of in the admitted setting, like we don't want to go down the road of coding ED attendances, but that there might be certain factors, whether that's behavioural disturbances or even, children at risk, sort of a list of factors which may contribute to the complexity of emergency department presentations. So the classification does provide a sort of a bit of a way in the future for us to incorporate additional variables. Just to see a bit of a classification side by side, so here's two different patients with essentially the same clinical profile but different ages. So under URGs, that all go into URG 29, which was admitted triage category 3, all other major diagnostic block groups. In the AECC classification, you can see it goes into a group labelled according to the diagnosis to begin with. So it's an injuries group, so injuries other, and then it's a sort of a complexity level. So if you're patient A, who's like a young patient, then you might go into complexity level A because of the age contributing to a higher complexity. Whereas if you're the adult patient, you may go into that same diagnosis group, injuries other, but in complexity group C. So that's sort of just, I guess, a bit of a comparison side by side of what it looks like under URGs and potentially what it could look like under the AECC, and that categorisation based more on diagnosis and putting emergency department patients more into diagnosis groups to begin with. So I don't expect you to see that price list. It's not, there's 181 AECCN classes, so they're not all up there. But it's essentially just designed to illustrate that there is a single price weight for each emergency department presentation, which obviously is different to the admitted acute model, which has a length of stay element to it. We use a classification which I also don't think you use called urgency disposition groups, which is basically like a less specific version of urgency related groups. We use that for our emergency services, which are generally small rural sort of first aid posts that are usually run by nurses, maybe with a local doctor who's available on call but is not actually based at the hospital. And a lot of those services won't be able to collect patient-level data, and they certainly won't be able to collect diagnosis data. So we still do, for those small emergency services, have a slightly different classification of urgency disposition groups. But the vast majority are priced according to emergency departments and the Australian Emergency Care Classification. We do have some adjustments to the pricing model. So on top of the new N classes, we do have adjustments for Indigenous patients, remote patients, and also for facilities that are remote. These are pretty standard pricing adjustments that we look to apply to most of our pricing models. So that was emergency care. Mental health, that's another big piece of work that we have spent many years working towards. One of the first projects I worked on when I started IPRA back in 2012 was a definitions and cost driver study for mental health. The mental health sector have for years been telling us that DRGs are not appropriate and diagnosis-based classifications are not appropriate, and that they wanted a classification that particularly focused on community care, with the idea of being able to create the right incentives about treating patients in the community. So it's been a multi-year project. We developed a new classification that was implemented in 2016. We did 2 years of shadow pricing in, there'd be 2021 and 21-22. And so that enabled us for 22-23 to actually price using using the mental health care classification. So this new classification applies only for admitted patients at the moment, so it replaces the ARDRG pricing model for admitted mental health, but we will look to, as soon as we can, replace it for community mental health, which is currently subject to block funding arrangements. So this is just a bit of a comparison of ARDRGs versus the mental health care classification. So ARDRGs, which again I'm sure most of you are familiar with, looking at major diagnostic blocks, and then going into particular diagnosis groups, like adjacent diagnosis related groups. Whereas the mental health care classification is based on the first variable is a thing called mental health phase of care. So it recognises that within a single episode of mental health care, that a patient's goals of care may change, that their status may change, that they may move from acute to another type or another goal of care. So that phase of care is the first splitting variable, and then we compare, like we group based on age groups, so separating child and adolescent, adult and older persons, and then various functional measures such as the Health of the Nation outcome scale. For admitted acute, we look at mental health legal status, that is whether the patient was voluntary or involuntary. And they essentially put them into groups based on phase. Actually, I might just move to my next slide because that might explain it better. Essentially, the groups based on phase, age, symptom severity as measured by HONOS, and There are 91 N classes for both community and admitted. I will just skip that one for the interest of time. So this is the probably a familiar cost profile. It's very similar to the admitted acute model. It's an inlier outlier model. But what it is, it's based on phase length rather than episode length. So a single episode may have more than one phase. But phase length is still shown to be the biggest predictor of cost, in the same way that length of stay is the biggest predictor of cost. And the AMHCC pricing model better reflects the cost of particularly specialised mental health and complex mental health patients than the current ARDRG model, which we're pretty pleased with. But essentially the pricing model is that inlier outlier model, similar to what we see for admitted acute. We have our average length of stay, we have our lower bounds and our upper bounds, and there is a different price weight for inlier episodes compared to outlier episodes. We also have adjustments, our usual ones around Indigenous and remoteness. We also have a specialist paediatric adjustment, so that's for patients who are seen in specialist paediatric hospitals. So even though age is one of the variables in the classification, we do separate child and adolescent mental health patients from others in the classification. That still doesn't quite account for the variation in cost that these patients are seen that is in specialised children's facilities. So we do have an adjustment to add on to that as well. So just to recap, like what the difference is, like currently there's an ARDRG price for each admitted mental health episode. In the future, there will be an AMHCC price for different phases within that one episode. I should say though, within admitted mental health, the vast majority of patients are actually phased, their phase is acute. But there are some facilities that do have different types of care that do see patients who are acute that then transition to intensive, extended or functional gain or the like. We do have an approach that if there is not mental health care classification data, so if the data variables are not reported, it does end up in an error class, but it's not an error class with zero funding. What we do is we revert back to the ARDRG price, which in most cases is actually less than the AMHCC price, and where it didn't derive as less, we have actually made it less so that we don't create an incentive to not collect variables or to manipulate in any way. We often do this, I guess, with our pricing models, particularly with new classifications. We come up with some sort of fallback pricing measure in the first few years to recognise that there is various levels of maturity in data collections, and if there's a high number of error classes because of missing data, we want to ensure that zero funding is not applied because that's too risky. But at the end of the day, we don't want to create incentives to not collect that data. So we do look at setting those prices to create the right incentives around submitting good data. So that's the admitted model. Community mental health is probably the one that has garnered more interest in Australia, I would say. Because we have been block funding community mental health since ABF was around. It's one of those services that we haven't had a classification, we haven't had reasonable cost data, because community mental health, they're often associated with hospital services, but they often haven't been part of the National Hospital Cost Data Collection because they're not admitted patient care. So we haven't had great cost data, but there is a lot of, I would say states and territories are nervous about such a significant change, but also there's actually a lot of support for moving to ABF for mental health. It's been a bit of a long road with mental health. Like it was initially, I think when we started, mental health clinicians like, there's no way you can do ABF for mental health. But I think they've seen how block funding does not keep pace with the rate of growth that we saw in the ABF model. So essentially, year on year, health services are losing out under the block funding model because the growth rate is not the same as ABF. And while governments are very committed to mental health spending and they want to ensure that there's sufficient community mental health support, there is that nervousness around, as with any block funding arrangements, how can they guarantee that that's going to lead to more activity and increased services to consumers? So the pricing model for community mental health has been quite a tricky one for us. So obviously the classification itself is quite simple. Similar to the admitted model, you've got phases, and so you've got phases which can go over multiple days. They do go over multiple days. But obviously in the community, that's not like an admitted patient in an admitted bed. There'll be some days where the patient's seen, there'll be other days where the patients aren't seen. Just because of the reality of delivering their services, there is sometimes a big gap between when a patient's last seen and then they do follow-up and they can't get in contact, and months later they may decide to close the episode. And so there can be a big gap between how many service contacts patients are actually receiving compared to what that length of that phase is. You might have a 3-month phase, patient might have only been seen 2 or 3 times during that. So some of the traditional models that we looked at, do we look at a duration-based model, and a per day based model, that sort of has sort of certain benefits and incentives, and it does certainly is the one that best explains cost. But it also does create incentives around keeping episodes open longer for the sake of getting additional funding, and also brings in risks about, I guess, servicing to consumers. If the price is just per day, irrespective of whether the consumer or the patient was actually seen, then there is sort of potential there for that underservicing to happen, which is not something we necessarily want to see. Obviously, a service contact model has its own incentives, good and bad. There can be incentives to just deliver more services for the sake of, counting more service contacts, more duration of activity, or probably even worse, there can be an incentive to not necessarily deliver more services, but just to report more activity, to change reporting standards to report more activity, to look like more activity was delivered. So all of these, were sort of policy decisions we had to consider about, what do we want to drive in the community pricing model. And so in the end, we went with a service contact-based model. It's not to say we would go with that model indefinitely, but in the initial rollout of the model, we think that's probably creating the best incentives. There's been research done by a number of organisations in Australia looking at how much time community health, mental health providers spend with patients, and roughly about 30% of their time only is spent involving consumer work, and of that, only about 20% actually have the consumer present. So we really did want to drive, I guess, activity and delivery of activity. And so we've come up with a pricing model that essentially has a fixed price for each N-class, but then a price for each service contact, and there is a different price for a service contact with a patient present. So the idea being that this will hopefully drive increased service delivery, increased service contacts, and particularly those where the patient and the consumer or their family is present. So we actually that's not subject to funding yet. We've done 2 years of shadow pricing, and in developing NEP 23, we need to consider whether it is suitable, whether it's stable, whether that's the way we want to go. We will, I'm sure, continue to make refinements to the pricing model, but we are very, very close to pricing community mental health with activity-based funding, which is very, very exciting. Okay, a bit on safety and quality. I think the thing with the presentation is there's so much variety in activity-based funding, so much you can do. So I think it was Mike, or maybe it was Jerry, someone mentioned the hacks. Was it Mike? Yep. Mentioned the hospital-acquired complications as some of the work that we do. So some of you may be familiar with some of our safety and quality measures. Essentially, all Australian governments agreed and made a commitment to consider how pricing and safety can be introduced into the activity-based funding model in 3 key areas. This was back in 2016. So they agreed on 3 key areas, which is sentinel events, hospital-acquired complications, and avoidable hospital readmissions. So that follows, again, a significant piece of work since 2012 that we've worked with another national agency, the Australian Commission on Safety and Quality in Healthcare, to look at, development of that hospital-acquired complications list and an avoidable hospital readmissions list. Very clinically driven piece of work, so that by 2016 we were at a good stage where we had quite a list with quite good clinical buy-in, which enabled us to look at measures around pricing adjustments to incentivise quality of care. So these are essentially the 3 elements in our safety and quality pricing adjustments. So for sentinel events, which are those very serious, should never happen, wrong patient, wrong body part, medication error leading to patient death. Fortunately, very rare, but there are about 100 cases a year of episodes with that, and so those episodes now get 0 funding. It's not a lot, obviously, it's more a sort of a policy piece, I guess, but it's about the message that government wants to send around those very serious sentinel events. So if there is an episode of care with that sentinel event, they will receive 0 funding from the Commonwealth. For episodes of care with a hospital-acquired complication, so there's 16 high-priority hospital-acquired complications, there is reduced funding for episodes where there is a hospital-acquired complication. Essentially, each hospital-acquired complication has a different adjustment rate based on what the incremental cost of that hospital-acquired complication is, and it is also risk-adjusted to reflect the fact that some patients are at a higher risk of developing a hospital-acquired complication. And so the HAC adjustment has been in place since 2018. The most recent one we've done, which started in July 2020 and July 21, was the avoidable hospital readmissions. So that involves a funding adjustment where the cost of the readmission episode is deducted from the index admission at the original hospital. That if the readmission happens at another hospital, that adjustment is applied to the original hospital that had that patient, with the idea that the reason that patient was readmitted was because of that complication that occurred in the original hospital admission. That is also risk adjusted as well, and obviously it does vary depending on what the NWOW is of that readmission episode. In terms of volume, as I said, zero funding for sentinel events, that's about 100 episodes a year. With HACs, there's about 125,000 episodes a year, so that's probably by far the biggest proportion. Avoidable hospital readmissions is a very tightly defined category that the Commission on Safety and Quality has gone with. There's only about 41,000 episodes that get identified as an avoidable hospital readmission, which we know is significantly underreported, but it's been quite a contentious area, and the view was that they wanted to ensure that they only captured those readmissions which they could quite clearly relate to the index admission. We know there are probably readmissions that are occurring for other reasons, or because of failure in community care or primary care, or because of chronic conditions not being managed in the hospital. But that's the approach that the clinicians wanted to go with, and we're a pricing agency, we're not clinicians, so we do go with what the clinicians want to go with. So that's our safety and quality work. So this is our new and exciting piece, and I am coming to the conclusion, so just bear with me. I'm sure a few people are starting to flag, myself included. So I've talked about, I guess, all of the milestones of activity-based funding, talked about COVID, talked about emergency care, mental health, pricing for safety and quality. We are so enamoured with ABF in Australia that we are looking to use it for residential aged care. And so this is quite an exciting piece of work for us. And there's not a lot to report on yet, but I'm just going to sort of forecast a few things that we will need to do, and I know it's something that is probably on the policy agenda in Ireland at the moment. Essentially, this comes out of a Royal Commission into aged care quality and safety. So we have Royal Commissions in Australia every now and then. They're essentially an independent review commissioned by the government to deal with sort of serious and significant issues. They have quite wide-ranging powers to compel people to give witness, to attend and give witness statements, and they essentially provide recommendations to government. And this Royal Commission looked into a number of aspects, so quality and safety, came up with some horrendous stories of some of the quality of care being delivered by some of our residential aged care facilities, and one of the many recommendations, there were 148 recommendations, there were a number of recommendations around a funding model and a better funding model to create better incentives for quality of care, and the current funding arrangements that the government was using was not fit for purpose for either the government or residents or for aged care providers. And so the government accepted nearly all of those recommendations, and one of those recommendations was the creation or the expansion of IPA to become the Independent Health and Aged Care Pricing Authority, and to provide pricing advice to government on residential aged care. So different to hospitals where we have a determinative function, this will be pricing advice to the minister only, but obviously if we make a recommendation about pricing advice, the minister will have a lot of explaining to do if it doesn't actually take on board what we've said is the price of delivering that care, I guess. Remains to be seen. Current residential aged care funding arrangements are very, very complicated. The current arrangements uses this thing called the Aged Care Funding Instrument, called ACFI, and essentially that's been in place for about 10 years. It's not something government's overly happily with. I don't think aged care providers particularly like it either. Essentially, aged care providers do assessments for their residents to put them into different classes for the ACFI instrument. I guess the profile of residential aged care has changed significantly over the last 10 years since it was introduced. Patients are residents, I'll have to get in the habit of saying. They're frail, more frail. Most are over the age of 85. Most will be in aged care for 2 years or less. And also with the current ACFI tool, almost a third of all residents are in a single ACFI class, in that highest ACFI class. So from the government's point of view, there was some concern about gaming around assignment to particular ACFI classes. But so the ACFI covers one proportion of government funding. There are then accommodation supplements, which are paid either by the resident. I won't go into what a RAD and a DAP is. It's very, it's basically where residents pay a contribution to their accommodation. That's means tested. If residents can't contribute, then the government will contribute for them on their behalf. There are a number of other supplements for things like oxygen and enteral feeding, and then there's also a consumer contribution to the daily fee, and that's taken away, and then you end up with a government subsidy. It's probably too much detail for you, but what's on the agenda for the future residential funding arrangements are threefold, essentially. So there is a new assessment tool called the Australian National Aged Care Classification, ANAC. So that's a classification which comes with its own bespoke assessment tool, which has been developed for the purpose of the classification. And so that assessment tool will be applied to all residents entering residential aged care, and also all existing residents in residential aged care. And that assessment tool is going to be carried out by an independent assessment workforce managed by the Department of Health. So facilities and providers will no longer be doing their own assessments. That will be an independent workforce doing those assessments, which I guess government's quite happy with. So that's the assessment side of it. Then there is a classification and funding tool, which I'll go into shortly, and that's called ANAC, and so that's the funding models associated with that. And the third component is where we come in, which is about the costing process. So obviously introducing a series of regular costing studies and a cost data collection so that we can actually accurately cost on an annual basis, similar to what we do with hospitals, in order to come up with a reasonable price. Perfect. So this is what the ANAC classification is. Essentially, it's only 13 classes. It's a very small classification, only 13 N classes. And essentially, it's driven by predominantly the mobility of the resident, whether they're not mobile at all, whether they're somewhat mobile, or whether they're independent with the mobility. And then depending on those mobility categories, there are different classes based on cognitive ability, other confounding factors that includes things like falls risk, pressure area, as I said, cognitive ability and dementia is sort of probably one of the biggest ones as well. So that's sort of what those 13 N classes look like. I will just skip quickly to what the actual funding model will look like. So based on that ANAC classification, the ANAC funding model associated with that essentially has three components. There is a fixed component, which is called a base care tariff. We're going back to tariffs for aged care for some reason rather than prices. But so essentially there will be a fixed base care tariff for facilities, which will be different depending on the type of facility, the specialisation, where they are they remote, are they metropolitan, is it based on occupied beds, available beds, that sort of thing. So there'll be a fixed component, and then there'll be a variable component which will be based on the ANAC class of the resident. So it's reflecting the fact that there are fixed costs for providers, but that also some residents do require more resources to manage their care on a daily basis. And there will also be a one-off payment for new residents into facilities to recognise the cost of the additional care provided to someone entering a particular service. There you go. I think I'm right on time. So I hope some of that was interesting. I'm sure there was a lot there. I don't expect you to take all of it away, but there's lots to think about, lots for you as health services and agencies to think about. Keep in touch. That's our website there. We've even got a YouTube channel, lots of videos on there. It's really great. So yeah, just keep connected with us and read about all of our work. And thank you very much.